Welcome. Good morning to friends in Asia. Good evening to colleagues here in California. Welcome to all. I'm Karen Eggleston, Director of Stanford's Asia Health Policy Program, and this Stanford's Health AI Week, I'm especially delighted to welcome you to our first annual event on AI for Aging in Place, Asian Perspectives. Three esteemed experts will be sharing their views on the promise of health AI for enabling everyone to enjoy healthy aging and avoid or postpone institutionalization, like in nursing homes. So first, we will hear from Professor Hongsoo Kim about how Korea, with the world's fastest aging societies, is building a comprehensive system for aging in place with AI embedded across population health, long-term care, and community. Professor Kim is Professor of Health Policy and Aging at the Graduate School of Public Health and Director of the Center for AI in Health and Care at the Artificial Intelligence Institute at Seoul National University in South Korea. Dr. Kim's research includes all of these areas, including care innovation, and she has conducted numerous government-funded research projects and received several research awards, including as a Fulbright Scholar, a Tukemi Fellow. She is currently an expert member of the WHO Advisory Group for UN Decade of Healthy Aging. And Dr. Kim received her PhD from New York University, where she worked as assistant professor before taking her job at Seoul National University. So after Professor Kim, next we'll hear from Professor Ma of Peking University. We'll discuss an economic evaluation of integrating AI-enabled diabetic retinopathy care into primary diabetes care in rural China. Professor Xiaochen is an assistant professor of health economics at the China Center for Health Development Studies at Peking University. As a health and development economist, Dr. Ma's research focuses on health decision-making and health system strengthening, particularly for disadvantaged communities in China, including leading several large-scale randomized trials on improving access to quality care through digital health and nudge interventions. And his work has appeared in leading medical and economics journals like Journal of Health Economics. Finally, we're delighted that Professor Wong will discuss his research, leadership, and policy experience in Singapore and China. Professor Tien Wong is a physician, scientist, innovator, and the Senior Vice Chancellor of Tsinghua Medicine and Vice Provost of Tsinghua University, China. He has worked and held senior leadership roles in Singapore and Australia, and is a practicing retinal specialist with a research portfolio on retinal diseases, ocular imaging, AI, and digital technology. Has had positions at National University of Singapore, Singapore Health, Duke, and US, and others. Has published over 1,700 peer-reviewed papers, given over 600 invited plenaries, received over $100 million in grant funding. So he's been recognized by several international awards, including the Singapore President's Science and Technology Award, and an elected member or fellow of 5 national academies, including the U.S. National Academy of Medicine and the U.S. National Academy of Inventors, including others in UK, Singapore, and Australia. So welcome, everybody. Thank you so much to our 3 speakers. After our 3 experts' 20-minute presentations, we will have Q&A. So please put your questions in the Q&A function on Zoom during the presentations, and I look forward to moderating that discussion. So Professor Kim, over to you.
Thank you. Hi, everyone. My name is Hongsoo Kim, as introduced. It is my pleasure and honor to be part of this session. For many years, I have studied a single question. How do aging societies organize and pay for care? And today, Korea is in many ways the front line of that question. Let me begin by framing the talk. Much of the excitement about AI in aging is about prediction and detection. Better models to find disease or risk earlier. This is really, really important question, really matters. But I want to step back and look at the whole system. Not only whether AI can detect something, but how a health and care system act on it. Because detection by itself changes nothing. A warning that no one follows upon helps no one. So the gap I care about is not the cleverness of the model itself. It is whether the system delivers. To explore that, I will use three national examples: AI care calls, risk prediction, and social robots. Each one pairs with the research evidence behind it. And underneath all three, I will keep return to one question: who actually gets reached? So here's my whole message in one line. Korea is testing AI for aging in place at national scale. The early results are encouraging, but whether it can reach everyone, not just the people who are easy to reach, is a system and policy question, not only a technology one. So why Korea? Because we are, in a sense, the testing case. The rest of the world is watching, because Korea is aging faster than any country in recorded history. We are becoming a super age society this last year, but by 25 years, more than 40% of our population will be 65 or older, up from about 19% today. And the shape of that aging matters just as much as the speed. Already, more than 2 million of older adults living alone. About 2/3 of them are women. For many of them, a single phone call in the morning may be the only human contact of the day. At the same time, Korea has real strengths to build on. Over 3,500 community welfare centers, a dense public network that reaches right into neighborhoods. And there is one more point I think is easy to forget. Even without AI, prevention works. A community prevention program in Korea improved older people's self-reported health, their walking, and their stress, especially among lower income groups. This is a reminder that technology is added on top of good basic care, not instead of it. That is the base we are now adding AI to. Korea is also not starting from zero institutionally, and this matters because AI does not work in a vacuum. It works inside a system. We actually achieved UHC back in 1989, and we have added public long-term care insurance since 2008. It pays for home care, daycare, nursing care for older people with functional needs. No means test, it only based people's needs. We have community social care service, and as of March this year, a new Integrated Care Act, which is meant to tie health care welfare together so that people can keep living at home instead of moving into an institution. On top of that foundation, something new is now happening. In 2026, this year, the government launched a whole of government AI care strategy. The Health Ministry and the Science and Technology Ministry working together with a roadmap and pilots to bring age tech to market quickly. And what is driving all of this is, in the end, very simple. A deepening shortage of care workers in a country whose working age population is already shrinking. So what you are seeing in Korea is, in effect, a large-scale public-private experiment, commercial AI service running inside public care. It creates real challenge and opportunity. And this is exactly, I think, why Korea case is worth your attention. So let me now show you how AI is actually being embedded. Three national examples, organized by a simple logic. I found it useful to think about care in three steps. First, assess. A light functional check out in the community to see who might be at risk of decline. Second, predict. Flag the risk of a fall, of isolation, of a hospital admission before a crisis rather than after. And the third, connect. Routing the right support to the right problem and the right time. Now, here is the key insight. Most AI today is very good at and pretty good at the first two steps. We pretty much focus on that in the aging field, assessing and predicting. Those are at heart modeling problems, and models are improving pretty quickly. The more hard part, first part is also hard, I admit that, but the hardest part and the part my own work focus on is the third one, actually connecting people to care. And this is hard because care systems are fragmented. Let me make the concrete. Imagine an old man living alone, flagged at a high risk after a fall. The hospital discharged him. The care agency has a waiting list. Local welfare office never heard about it. And 3 weeks later, he's back in the emergency room. The technology did its job. The system did not. So connecting people at scale and reaching everyone, not just the easy case, is much less of a model problem. It is a system problem. I would also point to the outcomes that matters here. It is not how many services we deliver. It is closer to days at live and at home, keeping people living where they want to live for as long as possible. So as I go through the 3 examples, watch where each one sits on this line. So excuse me. The first example is AI care calls. In Korea, a commercial service called the Global Care Call, built by Naver on a large language model, makes regular, natural-sounding check-in call to older adults living alone. It asks how they slept, whether they have eaten, how they are feeling that day. The conversations are then reviewed, and anyone concerned is passed to a human welfare worker who can pay a visit. What is striking is the scale. This is now used almost 60% of Korea municipality. This began as a single pilot in Busan in 2021 and reported response rates are around 96%. Now this is where my own research comes in. My team ran a nationwide mixed method study on how AI actually being used in commercial community-based social care. We surveyed more than 600 social care providers across the country, those centers, and held in-depth interview with frontline social workers. We found that AI care calls like this one are among the most common tools that agencies adopt, used mainly for safety monitoring, because this looks like, feels like a ground phone, not people talking, but AI talking. So acceptance rate is pretty good. So providers see real benefits, better reach, less burden on staff, but they also reported real barriers. I will come back to those. The companies have also published its own estimate of the social value created with the university, as you see in the box bottom. This is a vendor-reported projection. And all of these point to a deeper question. When a private company's AI makes first contact with vulnerable older people across the entire country, who is accountable? Who holds the data? How we govern private AI inside public care is a public, I think it's a public policy question, not a product question. So does personalization, next question and case is, so how does personalizing this call actually help? This is the focus of study my team published this year. Let me carefully separate what we observed from what we modeled. We began with the real data. In the AI care call program, among about 200 low-income older adults living alone, the baseline call success rate was around 75%, but it was uneven. It differed by sex and by income. So the reach was real, but it was not equal. So we built a reinforcement learning model to personalize the call. Instead of one fixed protocol for everyone, it learns which kind of program works best for which person, and it adapts over time. We then tested it in a simulation over 100 runs using the care call data and a second much larger data set. A community health survey is a representative survey data of more than 70,000 older adults. Compared with the standard one-size-fits-all approach, the personalized model raised call success by about 84% and lowered depression symptom by about one-third. Now I want to underline this. Those gains come from a simulation, not from a real rollout. So our next step, which we are planning to validate the model in the field inside the public funded care program. So I offer this as a promising detection, not a final result. Two more examples I will take together. Both are building blocks for the connect step. First, prediction. And this is is my team's another research. So let me be clear about this one. It's a public insurer collect data, so it allows a researcher like me to develop the prediction model, not by the insurer by themselves, at least at this point. Here is the data we used. When older Korean applied for long-term care, every applicant received the same standardized in-home need assessment nationwide. We studied the record of about 36,000 older adults, all of them newly entering home care. And in that group, the risk is real and early. About 10% who admitted to an institution within 6 months of starting home care, almost 19% within a year. So we built explainable machine learning model to predict that risk right at the point of entry. And because our case manager has to actually use it, we keep the model interpretable. The strongest predictors were clinically sensible, dementia and disorder-related condition. The point is not the model accuracy itself. The point is to direct scarce home care resource to people at highest risk earlier. This work is currently under review. Second, and the social robot. Korea has placed AI companion robot in more than 12,000 households, all government funded for poor elderly people. With the developed device cleared by the US FDA last year, they give daily check-ins and conversation. They remind people to take medication. They flag isolation or decline for a human worker to follow up. These robots are used to extend an overstretched workforce, not to replace it. And that is a deliberate policy choice. So those are the pilots. Now let me turn to what the evidence will reveal beyond them, the opportunity and the challenge. The same technology does not reach everyone equally. The older adults most likely to benefit, those who are isolated in rural area or on lower income, are very often the least likely to be reached at all. Let me make those concrete too. Think of an older woman living alone in a rural village on a lower income with no smartphone and little digital confidence. She's exactly the person whose tool could help the most, and she's the first one the system tends to miss in reality. The unevenness on the supply side as well. In the same nationwide study, my team found that only about 38% of community care agencies have adopted AI at all. And the adoption varied sharply by region. Providers pointed to the same barriers again and again. User reluctance, weak infrastructure, and too little staff training. So the very district within the greatest need may have the least access. I do not see this as a technology gap. I see this as a design gap. The system that is genuinely meant to reach the people has to do two things. It has to track who is missing, and it has to route back to them. And that has to be built in from the start, not bolted on at the end. So what did it really actually take to scale this well and fairly? I'd point to four things. First, universal by default. Support should reach people without their having to know about it or fight for it. The hardest to reach should not also have to be the most persistent. Second, connected across sector, health, long-term care, social care, acting as one system, not as separate silos. Each sees only part of the person. Third, predictive, not reactive. The system should anticipate decline and act early rather than wait for the emergency room. And fourth, independent evaluation. We have to keep asking who validates the result, and just as importantly, for whom the technology actually works. Measured against the outcome that matters, like days alive and at home. None of this is glamorous, but these are system level and policy level questions as much as they are technology ones. Let me end with one concrete next step, and it connects direct to Stanford. Working with the colleagues here, we are testing a method that turns a short smartphone video of how a person works into digital markers of frailty and cognitive decline. Many of you know do this kind of functional assessment studies. It's really painful for both the research and elderly. It takes a long time and large resources needed, and paper pencil based sometimes. So the way someone turn out to carry a great deal of information about their health by doing this digital based approach, if we find a good digital marker. And the phone can capture it, low cost, contactless, and repeatable at home, hopefully. The idea is cross-national validation, a method developed at Stanford. It's the first step we tested that algorithm on Korean data, so that a measure of function can travel across very different health settings. And that, in the end, is a small but real step toward building the connect layer I described earlier together. Let me close. Across Korea system, AI is widely adopted to find who needs help. But what we really need to focus on is we have to, this experience should scale up to reach for everyone. Thank you.
Thank you so much, Professor Kim. Now, Professor Ma, over to you.
All right. Let's see. Can you see my slides?
Yes.
Okay, cool. All right, good morning and or maybe good evening. Hello, California. In the next 20 minutes, I think let me switch gears a little bit to low resource setting, which is rural China. I think for us, for anyone do research in China, I think we are uniquely lucky. On the one hand, China is indeed a powerhouse to many advanced technology in AI. For example, in the Nature covered article about the DeepSeek, all the new advanced models. On the other hand, there are still substantial gaps to be filled, particularly to address those access and the quality of healthcare services and reduce the economic burden, particularly in the rural setting. So today I'm gonna presenting our ongoing work, which we're integrating AI to a specific eye condition, which is called diabetic retinopathy, into a PHC setting in rural China. Okay. Before I talk any like a fancy AI, let me start with this very low tech classic question, which is underused phenomenon. We developing economists or any other global health researchers are familiar with. Basically, there are many proved cost effectiveness intervention, which was not that which has surprisingly low rate of uptake. And in the context of China, over the past decade or so, my team has been working on one specific area, which is eye care in rural China. Those we believe are really low-hanging fruits, because if you can see, you can study well, and that will affect all this human capital and labor market outcomes. And for those conditions, actually, they are very cost-effective interventions. Some of them are very low-tech. For example, eyeglasses. We did a bunch of randomized control trials in rural China to improve this. But those questions, there are some general questions we test through RCTs, which intervention work, why they work or not, what are the cost effectiveness of them, how about the sustainability, meaning when the project is done, how can we continue that service for those disadvantaged population in that community, and the scalability, meaning if one trial works, does that guarantee it will work in different contexts? Now, those questions has been answered in such a low-tech setting, which is eyeglasses. But I think those questions and answers to those questions are still valid in the context of AI, particularly in the digital world, particularly for these two area, scalability and the sustainability for those clinically validated tools to be improved when they deployed in a complex healthcare systems. So I think for many of us have done research in kind of low resource settings, AI really is indeed a big help, and particularly for us do eye care services or eye care researches. Ophthalmology is indeed an area that many of the AI has been applied, even in the low resource setting regions. But it's a big but. Still, I think there's a big question, meaning how we integrate those new advanced tools into the existing clinical workflows and healthcare systems. This question is still, I think, very valid in not only in the previous low-tech setting, but also in the high-tech setting, AI. So far, I think there's big two gaps. Some of them already mentioned by Professor King's presentation, which is in practice, many of these tools, AI tools, has been focused on the very left-hand side, which is the diagnosis accuracy or validation, rather than going downstream to this entire cascade. Whether improved screening will transfer into the improved referral and ultimate treatment and the ultimate health outcomes in the practice. And in terms of evidence, in terms of research evidence, there's a big gap in the evidence base, which there's enough effectiveness in terms of the validation, but mostly concentrated on the output rather than the outcome, as I mentioned before. The outcome, the real healthcare outcome, cascaded care outcome. And also there are two big missing in terms of evidence. The first is why it works or not. They might go through some implementation science materials. The other is cost effectiveness, and whether or not those interventions are cost effective in terms of if you try to scale up in a large scale. Okay, so I'd like to use one ongoing project which my team has been working over the past 5 years to answer those questions. This is a project we apply or integrating AI and leverage on the health system strengthening strategies to improve the care cascade of the diabetic retinopathy in rural China. And we did that in the central part of China, which is Anhui province, 3 counties. A little bit on the DR, on the eye care condition, just one slide to give you some ABC information. And so diabetic retinopathy it's a very common complication for those diabetic patients. About 1/3 of them will have that, and it's a leading cause of visual impairment and blindness among the working age population. But the critical thing is that this cause of blindness is irreversible. Unlike other eye conditions, for example, if you're myopic, you just put one eyeglass on your face, then it's done. If you have cataract, you did a cataract surgery, then you're fine. But for this condition, if you don't do timely diagnosis and intervention, then the blindness is irreversible. So given this importance, and in every country, many countries, and the WHO, they have so-called guidelines. And in the case of China, actually the National Committee for the Prevention of Blindness, they have a guideline. And this guideline is, we call it ideal model. This guideline reads like, from the bottom PhD level, we set up a screening and the referral and the final treatment. From the very bottom PhD level, up to the county level and to the prevention level. So it's very hierarchical. As I said, it's an ideal model. Basically, it's read on papers, on the guidelines. But in reality, if you walk into any typical county, this table gives you how things look really bad. There's almost nothing. There's almost nothing in terms of supply side. There's limited healthcare infrastructure. Because if you need to do the screening, you need the fungus camera. There's no such kind of equipment at the PhD level, and there's a shortage of skilled providers. And also, there's a very weak or disconnection between the primary and the specialized care, which causes a lot of discontinuity in terms of referral and further treatment. And the demand side is also lots of challenges, awareness issues, and all the other bad compliance or behavior issues. Now, this right-hand side, the demand side and the supply side, not only for this DR case, but I think it applies also to many other NCD problems, not only in China, but all the other different low-resource settings. So in order to address that, we design and implement a trial, a study in Anhui, try to address that. We integrated the AI-enabled screening and combined with some health system strengthening strategies to integrate the AI into the existing healthcare services model. And it's a 4-year project. So I want to, for the sake of time, I think the next, I think have 11 minutes, I will focus on the central part, which is for the past years, we have our co-design with the local stakeholders, and we conduct feasibility studies to test our model. And then we go back and iterate and refine, and we imprint again, and we did a economic evaluation, why and what would work in terms of implementation and economic analysis. And in the future, actually, this future is coming soon. We are designing our RCT protocol to run out a full-scale trial to test our model. Okay, so just give you a very quick data. For that DR things, the regular or the usual care actually has a very low rate of screening, less than 1/3, for all kinds of reasons, as I mentioned in the previous slide. And what we try to do in the first, we call it 1.0 version, that's in the year 2023, 2024, it was co-design phase. We work with the local stakeholders, trying to set up this AI plus model. Basically, it's we call it system integration. We leverage our service delivery with the existing, let me explain what does that mean, the county medical titan alliance. Basically, it's a county level vertical integration organization, which goes from the county hospital and the township hospital and the village clinics. That's vertical, and the vertical organization. And also we have so-called service integration, which we integrate the DR service, diabetic retinopathy, into the national, the basic public health service program. Now, this national basic public health service program is a public health service program which provides you the essential package. For example, NCD management, which including the regular check and follow-up for this diabetic patients. And it also includes the educational campaign, health promotion, extra. So what we try to do is we try to integrate our AI, the tools, with the existing system. So in order to remember, there was nothing to begin with in the PhD level. So what we do is we try to put the camera in the county, in the township level. And those township GPs, they can be trained just to click the mouse to take the photos. And the photo will be transferred to the county level, which will be grading by AI. In that case, those patients will not travel a long way to the county level to do the diagnosis. Therefore, these hospitals, in the county hospitals, the doctors, their manpower can be released in order to do the treatment. So basically, we put all these servers cascaded down to the one level that gives improve the reach and the accessibility in the primary healthcare setting. Okay, so I will quick go through this. Good news, it improves a lot of this screening from the less than 1/3 of screening in the usual care case to over 85%. Okay, so it's a good news. But the bad news is the referral and the treatment still very low. If you put these two together, meaning the proportion of VTDR means those who have DR, which has stress, which is threatening their vision. Okay, so those people really need a care treatment, either by laser treatment or by injection some medicine, VEGF. So only like 1/5 actually get the actual treatment. So take it, 85% got screening, but only like 21% got the actual treatment. There's still a big gap. So this is bad news for us. So what are we gonna do? And in the year of 2023, 2024, we go to another round of optimization phase. We call it from, we basically updated from 1.0 version to our 2.0 version, meaning adding 2 additional strategy to improve this referral and treatment. One is called point of screening countdown. So what does that mean? In the previous 1.0 version, when they did the screening and they go home and wait about 1 week to get their results, Usually this result come with a letter, but for those, let me repeat. My setting is the rural areas of China, okay, with a limited educational literacy. So they don't understand what does that mean in the letter. Basically, it tells you, oh, you are positive, you have to go to hospital. This kind of information will not generate any behavior change. So we did this, is like called point of screening conduct. Basically, immediately after the screening, the results will be out. And we generate a standardized communication toolkit. Basically, it's a local layman language version of information. Tells the patient, hey, you gotta go to hospital. Otherwise, you'll be this and that. So this is called point of screening conducting. Hopefully, will improve their compliance. The second is enhanced follow-up. We integrated our follow-up with this existing national basic public health services. Because remember, I said in the national essential public health service programs, the village clinics, they're supposed to visit those with in their NCD management patients. They have to be follow-up for at least 3 or 4 times, 4 times quarterly the NCD management cycle. So we try to integrate our follow-up combined with their existing national essential public health service follow-up. And these two strategies hopefully will increase the entire care cascade, meaning from the screening to referral and treatment. Okay, so the next few slides, I'd like to share you a few economic evaluation findings. Basically, then it's a modeling work that models how, if we implement this 2.0 model, whether or not that will be cost effectiveness compared to the no screening, basically it's the usual care, and also compared to this, we call it AI screening, that's our 1.0 model. For the sake of time, I just tell you the results. Our 2.0 called AI plus model is dominating. It's dominating on all metrics. Also, if you look at the factors that influencing this called ICER threshold, the treatment compliance really matters. The treatment compliance on the top, that's the biggest factor. It's the biggest factor that affects the care cascade. And it's a driver of our cost effectiveness outcomes. Okay, just let me try to run up. Now we're moving from the screening to the entire cascade. And in terms of evidence, we're moving from the why it works to the cost effectiveness. The next step is we run out a full-size randomized control trials in the year. We're actually developing this protocol for that. So basically it's embedded randomized control trials in that AI program, because we already run out a 1.0 version of AI screening. And in the new RCT study, we will put this 2.0 version with two additional components. One is point of sight screening conducting, and the other is enhanced follow-up. And we will look at both the process evaluation in terms of fidelity, reach, and adaptation, and also the underlying data in terms of the health outcomes and all the other the real referral and treatment. Okay, I think I have 2 more minutes. So I think both Professor King and my slides from different angles, I think we try to emphasize one thing, which is integrated to or let me put it this way. We have to put AI, these new advanced tools, into a broader holistic perspective and try to leveraging the existing healthcare system to maximize the uptake. I want to echo Professor King's one side. She mentioned just screening is not enough. I 100% agree. So I think down the road, there's many works. Either we should combine with vertical integration with the vertical healthcare system, also the horizontal vertical integration integrated with the existing diabetic care. I think Professor Wong has a lot of work which I set in this slide. Okay, to summarize. So this program, we try to fill the two gaps. One is the practice. We move from screening to entire cascade. And then second is evidence. We try to fill the evidence gap to provide the evidence on implementation science and the cost effectiveness. And finally, we will try to fill the evidence base of the trial through a randomized control trial. And I think this is my last slide. And let me just stop here. Thank you.
Well, thank you so much, Professor Ma. And finally, Professor Wong, over to you.
Thank you very much, Karen, and I'm very pleased to be here and to share this really interesting session. Of course, we learned quite a lot from Professor Ma, particularly on diabetic retinopathy screening, which we have quite a bit of experience, and I'll say something about it as part of my talk, but I'm not going to cover specifically on eye diseases itself. So let me maybe reframe where we are at with AI, addressing aging and some of the global health challenges, essentially, right? And I think the first is to look at medical practice. I'm a physician, and I was trained as in the traditional medical school, right, under what are called the Flexner report, right? So it's a very physician-centric way of looking at medical problems, essentially, right? We have a biological basis of disease. We look for biological solutions, typically drugs, and then we have sequential learning from normal to abnormal. By the time I graduated and started practicing 20 plus years later, the whole healthcare system has changed, in which we are looking at physicians in a team, and therefore we're looking at healthcare systems, social determinants of health. So what we eat, what we drink, the air we breathe, those are important determinants. We're now moving into a new era, and I think that era is not clear to everyone, and I think we are still trying to understand what it is, right? But essentially, the physician will be working either with the AI or even in some scenarios replaced partly by AI agents. How much and how many, I think, is meant for debate. And we're working in digital systems, so it's even larger systems than just health systems, because it's systems in homes, in our work, and so forth. And I think that the systems are not static, so they are not confined to just hospitals and the surrounding academic health centers and so forth. And I think we need to understand that. And I think that's something that all of us are grappling with, whether it's in the US or China or Singapore. I'm going to cover the following, right? Some of the global health challenges. Many of you will be aware of it. We've touched a bit already on it. And I would look at and framing how do we use AI to solve some of these problems with the 3 W's, right? Why do we need to do something? What do we do? And who is this for? And I'll use eye diseases, which I think Professor Ma has also spoken about as an example. Then I'll say why the AI adoption in healthcare has been slow and really quite frustrating and, in one sense, disappointing. And then how do we prepare for this enabled ecosystem? And I'll give another 7 Ps for us to end this session, essentially. So let's look at some of the major challenges. So aging creates many challenges. It leads to what I'll say multi-organ, lifelong chronic diseases. So if you have a disease, for example, diabetes diagnosed at the age of 45, which is quite typical, then you have almost another 45 years of living with the disease, right? And how do we live with the disease? How do we manage that disease is a big challenge for many healthcare systems. That then leads to significant disparity in access, particularly in China. And this shows you the concentration of, hospitals buildings. And this is the tertiary type hospitals, those major hospitals, and still very much concentrated in a few areas. And therefore, leads to, inadequate access and disparity. This also leads to problems that has not been addressed very well in many countries. As we are all aware, US spends 17, maybe close to 18% of the GDP on health. China is about 7% now. That's insufficient, but certainly many countries cannot grapple with it going towards the 10%, 12% range of budgets. And there's insufficient number and quality of physicians and nurses, partly with training, and that's always inadequate, particularly in China, where being a doctor is not seen as as a well-paid profession with long and good career tracks. And therefore, that leads to other problems in China. For example, primary care is particularly weak. So what you can see here is that 1% of the hospital sees 38% of the patients in China because everyone congregates there. So if you have a flu, if you have a little bit of sore eyes, if you have a headache, you have no choice but to wait in the emergency rooms of tertiary hospitals. And that's always very common, particularly in major cities, essentially, right? So that's a challenge in China and in many of the Asian countries that has not been able to develop this system. This leads to situations like this. This is there's a hospital where I practice, and many patients come in for sickness. This is during COVID, and you can see coming for intravenous injections and so forth. And therefore, we are not adequately adaptable to managing aging and multi-organ diseases. And therefore, it leads to outpatient clinics that are like this. And therefore, this whole idea that, if you have a chance to come and see a doctor, you're able to make that appointment, but well-defined long-term follow-up appointments and treatment plans for chronic diseases like diabetes, like eye diseases remains a problem. This is one of the clinics that I work in, and one of my colleagues, and you can see that because there's too many patients, inadequate access, and therefore it leads to inadequate patient education, so they don't understand the disease. The doctor has no time to explain the treatment options, and therefore there's a lack of trust. So many patients seek second or third opinions. I hardly see patients that have not seen other doctors before, and then that leads to a vicious cycle. So in other words, instead of them having one outpatient visit, they could have 3 or 4 for the same problem. Similar problems in Singapore, and I won't go into the details, but in many countries, in Korea, in Japan, in Singapore, aging problems has created this kind of issues. And therefore, if you are looking at these challenges, can AI address it? And of course, if you look at it, it really can address many things. For example, it can assist in screening, triage, diagnosis, and the initial management, particularly in community and primary care setting, which Dr. Ma has already spoken about. Hopefully, it can increase access and not increase inequality, increase access and reduce inequality, improve the hospital efficiency, supplement and assist physicians, using those kind of co-pilot model, increase diagnostic rates and so forth. So the potential is really there. In China, of course, there are many things that's happening. AI is a national priority, and the strategy, unlike US, for example, is open source models with broad applications, and very different from models in US, where it is still closed source, and proprietary to commercial organizations such as OpenAI, Anthropic, and so forth. China is rapidly pushing the concept of AI plus application, and this shows you, a lot of AI applications and the adoption in many hospital systems. Of course, that has come with risks and challenges because of the inadequate policy support. Companies such as Alibaba Health has also started looking at providing physicians with tools that is no different and like the Stanford and US, where people use open evidence, and this is in partnership with JAMA, with BMJ, and so forth. And there's many tools that allow the doctors to use some of this.
基于自研医学大模型、自建医学库，直连国内外最新指南、共识、文献，所有问答均有权威出处，不引用互联网不实信息，支持动态证据定位，一键直达信源。氢离子支持指南文献一站式搜索，与 PubMed 同频更新。告别关键词支持一句话搜索，你可以一句话搜文献、搜指南，怎么搜都能直达精准信息。
Yeah. So these are some of the kind of applications that's been developed in China that maybe non-Chinese kind of maybe the Western world is not that familiar with because it is really meant for Chinese physicians and so forth. So let's take a look at a very important thing. What do we use AI for, right? And I would suggest that we look at it very clearly because there are many developments, as Professor Ma has said, there are many developments and validations, but very little usage. And I think not understanding this is that the problems are important. So first, it is very important to understand what happens to patients, and I'll use eye care, but it's really any care, right? You have the first group of patients that do not know what to do. They do not know who to seek. The second group of patients that go straight to what we call the traditional tertiary hospital. And the third group of patients represented by the figure here that maybe sees someone in the community or primary care setting, right? So basically three groups of setting. When these patients, some who do go to the tertiary hospital, they end up with many complicated tests before they end up in the hospital, before they end up going home. And within the hospital, they might have treatment or they might have more tests and so forth. So it's a very messy situation. And many patients are stuck in what I'll call hospital care. So this is the current situation. When you have the current situation, you need to know what problems. And I do suggest that many engineers and AI scientists don't understand what they're trying to do, right? So the first is, are we trying to address inadequate patient education and access? Are we trying to have under or over referral of patients to the hospital systems? Are we trying to look at solving the fragmented care pathways in very inefficient hospital systems where very few patients are seen correctly and many patients are seen by specialists that they do not need to see? And treatment decisions, clinicians are dependent on varying level of evidence from really their own experience or their own way of acquiring knowledge. And therefore, these are what I'll call the whys of what we want to do. So we need to know the whys before we're able to develop the solution. So once we know the whys, then the solution of what and where can the AI be applied comes in place. So it's either addressing patients, it's either addressing screening, of which Professor Ma provided a very nice example for diabetic retinopathy. It is addressing the pre-consultation triaging functions. It is addressing the clinicians' decision support, what we call clinician decision support systems, or is it addressing something for predictive and prognostic to let the patients know what their treatment outcomes are, or are they supporting patients when they go home with adequate education on when they need to go back to the hospital, and of course, maybe even increasing the hospital efficiency. So I would suggest that the AI applications are very specific and very targeted. And the last W is who is it for? So if you look at the situation of what I mentioned, if it is a health chatbot, it is addressing public and patients. It has nothing to do with doctors and hospitals. If it is looking at screening of diseases, it's really at the primary care level, for example, optometrists. If it is at the pre-consultation and triaging level, then it's going into the general ophthalmologist, including diagnosis and clinician decision support. And then the predictive and prognostic and patient support are really treating subspecialists. And of course, hospital operations are for administrators. So I think sometimes when we look at a development of a model or an algorithm, we are not able to address why is it not used, because we don't understand what problems they're addressing, and who is it for? Is it addressing for? I think those are very important things, and that's how I look at it from being in this field for the many past two decades or so. Let's look at another major problem, which is why is the adoption slow and somewhat disappointing? And the way to look at it is the following, right? First, current AI models are still done in what are called laboratory settings, right? They are useful for structured tests in a classroom MCQ setting, so they can address, for example, the New England Journal of Medicine case reports because they are very complete and they are very comprehensive. They do not reflect the real world clinical decisions making that, for example, when I run clinics that I see, right? Incomplete information, lack of details of previous treatment, unclarity about the history, needing multimodal data, and then the physicians sometimes use intuition, reasoning, experiential knowledge. And I think that these models have not been able to integrate into this system. The second is that I think AI has struggled to create value, right? It has created information and data, but it does not help, busy clinicians and healthcare systems. So many physicians struggle to do it. We have tried to use an AI agent in some of our local hospitals, and after a few rounds of putting this into the next to the electronic health records, many physicians stop using it because it really has not helped them. It has slowed their work. It has not improved the quality of their work. And it just adds on to what we'll say information or alert fatigue. Why do I need more information when I need to make a decision quickly about what it's going to be able to do? I think the current models are not evaluated for clinical care needs. You can see that many of it are still looking at what I'll say the development diagnosis range, and few are looking at, we've also mentioned it, in the previous speakers about care coordination, improving continuity, and deployment considerations. I think current models are very difficult to generalize to local clinical contexts, and I'll give you a very classic example. This Google's landmark AI algorithm for diabetic retinopathy screening that was developed using kind of open type data sets, and it's a very high efficacy. It has a 99.9% accuracy, but when it was implemented or tried to be implemented in countries such as India and Thailand, it struggled because it really could not understand the local clinical ecosystem. And that therefore means that the implementation, the kind of failure that was mentioned by Professor Ma. I think the ability for physicians and for to trust it, we either have too little trust or too much trust, I think is an issue essentially, right? Why do I mention that there's too much trust? Because sometimes patients are trusting medical generated advice, even if it is a false advice. And there's now nice experiments to show that when large language models come up with false and inaccurate advice, but because it's from AI, so-called, it was trusted essentially. On the other hand, physicians tend to not trust some of the AI algorithms. So I think that has continued to be an issue. And then I think the current models have not been able to, I will say, unmeasurable data-less part of the healthcare system. What are those? Those are feelings, emotions, anxiety, the ability for patients to want to have connection and to have discussion and to have support, and to have a listening ear, right? Rather than to have them solving problems. And this is some of the patients that I've interacted with. I can't capture these information. They can't be captured in models, essentially. So lastly, I would say, what's the way forward? How do we prepare for the AI-enabled ecosystem? As Professor Ma has mentioned, in diabetic retinopathy screening. We also developed a screening model in the mid 2010s up to 2017, and we implemented this as a national AI screening program in Singapore, and it took many years and is still really much in development. When we look at that case study of how it's used in the national screening program, there were many lessons. I won't have time to go into all the lessons, but I'll summarize it as 7 Ps. And this gives you a sense of what we need for the ecosystem. The first P is that we need people, right? Rather than just having engineers and AI scientists or doctors, we need several groups of people coming together, including patients, including the public. And I've always worked with computer scientists. I've always suggested that computer scientists coming to us with AI products, which happens with Google and many of the tech companies, do not understand the clinical problem and the clinical context. The second P is platforms. We need data and digital platforms, and we need real-world health data and the process with an implementation roadmap for us to use the data and the platform before we even develop what I'll say is the model or the product. Right. So in other words, currently many products are developed without considering the people involved, including the patients and the public, and without having the platforms and the process with real-world data. And that is a challenging situation. Then I think we need significant partnerships, policies that allow us to be able to implement and use this technology. And I think very importantly, payment and a sustainable business models. Many times, a lot of models are given so-called free to local governments to use, and when it's time to integrate some of this, there's no payment. When there's no payment, it's not sustainable, and therefore there are many what we call nice little pilots in many different situation and communities, including in China. Many local governments like pilots, but is not able to integrate it into, for example, the national insurance system for it to be paid. So let me summarize by this kind of short talk by saying that it has the substantial potential to transform medicine, of course, and address some of the aging challenges, including diseases and healthy aging. Research has progressed rapidly in the technical aspects and performance, which I won't go into. I think all of us are aware about it, including some of the large foundation models. However, most AI models are not yet ready for clinical use and at the moment does not seem to be able to replace many of the core functions of the physician. So we're not really in the AI era yet. We are still in that transition. I think that building the ecosystem, it requires really understanding how do we do it. And there are not many examples of a successful, deep end-to-end implementation of AI in healthcare to address these challenges. So I think with that, I'd like to thank the chance to speak about this from China and from an Asian perspective. Thank you very much.
Well, thank you all so much for those fascinating sharing of your insights and experiences. So we have a few minutes left for Q&A. Those listening, feel free to enter additional questions. I'll kick off with asking some and open it up to our panelists also if you have questions for each other to focus on themes that are cross-cutting, where you all talked about going beyond a technical issue to think about system-wide ecosystem implementation and all those related policies to bring real social value. One of the questions that we have from our audience is about your insights or advice to specific stakeholders. So one is, what would be your recommendations to health startups? I will add to that, for those who want to speak to it, we have many students and emerging scholars listening to this series. What would be also your recommendation for providing evidence about what works in specific settings? Do you have then ideas you want to convey to the startups and to the evidence generators at a broader policy level? Any thoughts would be welcome. Professor Kim, do we want to start with you?
I think Professor Wong's the last slide, the 7P, I think include the answer. I think the collaboration between the engineer and the domain and tech experts come together, work together. So start from the practice, the clinical setting, the real people. The answer is there, I think. That's my short answer. Thank you.
Yeah, maybe I'll chip in a little bit about this because many startup companies have approached us. China, there are many startup companies. I think there are a few things which I mentioned, but I think some are worth emphasizing again. I think startup companies have always very good ideas that are conceptual. I think in the healthcare space, it is conceptual because I've encouraged my engineers to spend a day in the operating rooms or in the clinics. In Stanford, there's a biodesign program that I think Karen knows quite well, whereby they bring the engineers and the physicians and so forth together. And they spend 6 months trying to look at a problem, trying to address using engineering or policy or business solutions, right? But the business part is very important. So in other words, when the startup comes with a nice idea that they have with their maybe technical friends or engineers in a coffee and say, this looks like a great idea, but when they already developed the product and they go to the physicians, typically what happens is the physicians will say, well, it's okay, it's interesting, let's try it out. You put it in the clinic, no one uses it, and you get into some of these kind of problems. So I do encourage startups to really, number one, before they even have a product and the idea, to understand the problem, which is why I put down there the why is very important. That's the first thing. The second I would say is that unfortunately, the users of healthcare are not very much involved in AI. And I want to emphasize this. Many people ask me, which physician should I approach? And many physicians are not trained in AI, are not interested in AI, are waiting for things to happen, essentially, right? By the time it's mature and usable, it's a little bit late, essentially. So I think that we are also lacking a little bit in this space. And there's a lot of reasons for that. Doctors like me are trained in traditional non-AI era. By the time they are attending doctors, in their 40s or 50s, they will have not missed and will have no AI era training, right? Whereas, the startup students and so forth, they're still in their 20s and 30s. They are embedded in the AI era. So you do need to wait for maybe 10, 15 years for some of the physicians who are now trained and using AI for you to be able to do this. So I think a bit of patience from the startup company is quite important.
Any other thoughts on that question?
Yeah, sure. I'd like to echo and provide some additional 2 cents from the perspective of economics. I think first of all, from the behavior economics perspective, we have to start with again, my setting is PhD and the rural areas. We have to start with some environments they are familiar with. For example, we have a failed randomized control trial, try to provide those village clinics with some advanced digital medicine, digital technology. It turns out 95%, they don't even open it up. All those wearable equipments, all those different fancy digital stuff. They told us they only familiar with the WeChat. Anything apps or any like digital tools, if that's already embedded in WeChat, they are more likely to use the uptake. So that's lesson 1. And second is, I think from the conventional economics perspective, you have to align with their incentives. Because when we talk about many PhD, they are already overwhelmed of their job. They're already overwhelmed, overstressed. So if you have another like vertical injection of a different project, you better align with their incentives. You better, for example, the reason I think this project works okay because we align with their daily incentive on NCD management, where basically our tools are helping them to doing their own job rather than doing job for us as a researcher. So I think there's are two things. One is start with environment they're familiar with. Second, to align with their routine incentives.
Thank you. So I'll add one question to think about. It came up briefly in different perspectives in each of your talks. A question about sort of the ethics about thinking of social value that AI-enabled processes and technologies will bring to our health systems and aging in place. So how do we think about the benefits versus the harms of, in medicine, there's a well-defined way of bringing new technologies into practice and evaluating them. But what about the benefits and harms of not using a technology and not reaching out to those that we could with AI-enabled technologies? How do those figure into the governance process and policy? Any thoughts on that ethics of harms and benefits from use or non-use?
Yeah, maybe I can start
up.
again. Thanks very much. We've been struggling a little bit with this, and I think there's a very two interesting papers that's come up recently. One, what we call the inverse care law, which is as AI becomes more prevalent, it accentuates inequality, right? And the other, which is even worse, which is just published in the Lancet, is the recursive care law, which means that not only is it increasing inequality, but the vicious cycle makes it embedded in the system. And therefore, Karen, your point is very important, right? As AI technology becomes in the hands of technologically savvy users, number one, as the data becomes embedded in rich countries and the models are much better at predicting outcomes, are better used in countries and systems with good data and with good resources, with good payments, then this technology would not be used in many of the places of need, the gaps. Global health is one, but you can also say aging is another, because it'd be preferentially benefiting younger people who are technologically more savvy, and therefore there will be more data in this, and then embedding that the older people which do not contribute as much data, the models are not as robust. So I think these are very important things, and they can only be done at governmental level, which must require fair data coverage, fair usability, just like what we do for many policies, essentially. Then that will cover the ethics of some of these things. Yeah.
Thanks, Hongsoo or Xiaochen. Any thoughts on that?
I also think the concern is the inequality will be wider and deeper in multiple levels. So some policy become more matter and governance really important, but sometimes I'm recently skeptical we can overcome this issue. You really answer. You have to be more serious about it. We talk about it, but the real action is not much active. So this has to be on the table, I think. Now. Thank you.
Xiaochen, did you want to add anything on that?
Oh, sorry. I got muted. I think that's really context specific. Let's look at the DR case. Our case, it's AI is dominating. It's very cost effective. But our case in rural areas, the AI story is an augmentation story, because it's nothing to begin with in the rural context. There's another paper coming out a few years ago in Shanghai. The story is a replacement story, meaning Shanghai already has a manual grading DR system. And their analysis is AI is actually not cost effective compared to the manual. So it really matters which context they're talking about. I mean, I think it's all boiled down. It's again, For me, as I start my slides with a very low tech context, I think those low tech contexts, there's a still classic questions, which is this technology adoption, is that the replacement story, or is that augmentation story? Or in other words, in a very economics ABC, is this a substitutes versus the complementary? When we look at this, the machine-human interplay. So that really matters, which context and which interplay, machine-human interplay we're looking at.
Thank you. So we have a question asking maybe more on the optimistic side. What are you most excited about in the future of AI for aging in place? Who would like to kick us off with that one?
I'd like to add maybe just from my setting, I think there's a lot of potentials. There's a lot of potentials. However, the real application, it takes a long way to go. So in terms of the most exciting area, I'd like to frame it as what is the most practical? What's the most practical way, or what's the feasible way to increase the scalability and sustainability? I think that's something I'm really excited. That's a question that excites me, interests me, rather than what's the most advanced technology or what's the most. Or again, those parts are important. But from my perspective, how can we reach as much as possible the scale in a sustainable way to the population? That's something I think that's a billion-dollar question.
I maybe echo what Professor Ma mentioned. You don't need the most advanced foundation model that OpenAI and Anthropic are developing, right? These are what I call Ferraris, right? You need a normal, simple car to get us from point A to B. I think using older models, when we did this program in Singapore on diabetic retinopathy screening, we use a very traditional deep learning model. It doesn't need a foundation model with multiple specific tasks. But the process of implementation, which is what Professor Ma also mentioned, does require a sustained effort to push the boundaries. It requires that multi-stakeholder teams, which is at the moment not really easy to form, right? Addressing a single problem, pushing in a very dedicated way with those 7 Ps I suggested, right? Policy level support, economic analysis. We did economic analysis because that's what healthcare governments want, essentially. But also pushing for a reasonable payment model. So the payment model, it's 25 Singapore dollars. It is not expensive. It certainly did not save a lot of money, but it was sustainable from the government. And therefore, that meant that this program will continue. It was not using the latest, kind of foundational large language model, the standard machine learning, deep learning model. And I think that that's what we need to do, essentially. Then you will start showing impact. And therefore, I think people will start saying, this is sustainable, it works. Let's, invest more on using AI in healthcare, or we keep having nice foundation, new models that are, at the periphery of our healthcare system.
I also agree with the two colleagues. I think what the AI model, what technology we really need, it's maybe not the most fancy one. We have to be clear what the problem we are facing. We need the right dose AI model we need. And the most I vision for the AI in AIP is I really want to empower people, the caregivers and elderly family caregivers. And empower them, and they can really care themselves. They realize that I can take care of my house by myself pretty much. So empowering, using AI for empower them would be really be great.
Great. Thank you. So, as we all know, AI for aging in place and aging and multiple organ systems, it's a life course of exposures and behaviors, right? So, I'm wondering your thoughts about as cohorts are born into an AI-enabled health system versus the current older adults, are we going to see changing effects of these health systems developments over time? And do you think that policymakers should take that into account? And finally, related to that, what do you think should be the topic of our AI for AIP next year when we focus then on questions about what works in different care settings um, for looking at AI-enabled systems, policies, technologies that actually work in practice, provide solid evidence that might inform across different care settings. So that's a whole bundle of questions. You're invited to respond to any piece of that that speaks to you for our final few minutes.
I would like to suggest that we need better user case studies. The recent Nature Medicine editorial is very widely read, right? Show us the evidence of value, right? So, a topic would be, case studies showing value of AI in healthcare, right? Not models, not nice performance, not nice benchmarks, right? What's the value? Does it improve, for example, screening rates? Does it lower mortality rates after they are screened? Does it improve, for example, Professor Ma's example, right? I would be asking, has it reduced blindness in diabetic patients in that cohort that was screened, right? That would be whatever it is, right? Is it 20%? Is it 30%? That will be what I would like to see. I don't think that there are many of these things here. And Nature Medicine and other journals wants case studies as well as those that shows lessons, including failure lessons. I think we need some lessons in which what does not work as well, essentially, right? Because otherwise, it's only one side of the story. So that's what I suggest for the next year's seminar, essentially. Thank you.
I want to echo that, particularly last sentence. What can we ever learn? What to facilitate this knowledge exchange? Of course, we learn and we are celebrating those published papers. But I think what we learn most, at least from my perspective, is my failed randomized control trials. Next, I would like to present. I have at least two very large scale, but with negative non-outcomes. And as I said, particularly in terms of one, we do not generate enough incentive. B, we didn't start with a behavior that's aligned with their own routine behavior that can generate behaviors. And I think that lessons we can ever learn. That can be generalized to not only in the eye care but also other different settings. So yes.
I think how AI can improve the integrated care, that evidence will be very interesting because that's one of the very challenging question to make people really make living in the community, AIP. But as we three people talked, systems really fragmented. So AI can really help. What evidence? What's the value? That would be really interesting. Thank you.
Great. Well, we look forward to continuing the conversation, but thank you very much for your contributions today, and thank you all for joining us. Bye.